Immunotherapy targeting PD-1 pathway has demonstrated significant efficacy and is the ideal treatment in dMMR metastatic colorectal cancer and also offers modest benefit in patients with biliary tract cancers when combined with chemotherapy. But there is a lack of new predictive biomarkers to select ideal candidates for immunotherapy with a demonstrated clinical value. And the identification of biomarkers of ICI response for GI cancer patients with a poor prognosis is also important given the long-term benefit and reduce side effects of ICIs compared to other systemic therapies. So we can keep these patients on ICIs to ensure a greater duration of treatment benefit. One emerging potential biomarker is POLE, which encodes the catalytic subunit of the DNA polymerase epsilon enzyme and plays a critical role in DNA replication and repair. But POLE mutations are very rare and found in only 1 to 2% of colorectal cancer patients, and only a few instances reported in literature for gallbladder cancers. There's also a scarcity of data regarding POLE mutant GI cancer population and lack of a standardized therapeutic protocol, which is tailored to these specific patients. There are no clear guidelines on the duration of ICIs, where data is often extrapolated from dMMR CRC patients. So to address these questions, we analyzed 3 adult patients with colorectal or gallbladder cancer who carried a POLE mutation identified via commercial liquid biopsy platforms and were managed with ICIs after diagnosis. We reviewed their clinical management, radiological outcomes, and post-operative pathological evaluations when applicable for these patients. We also explored additional genomic mutations, tumor mutation burden, and along with the microsatellite stability profile. So the first case is a patient with metastatic gallbladder cancer who was managed with GemCis with durvalumab for 4 cycles, followed by durvalumab only due to chemotoxicity. And in this patient, we observed an exceptional treatment response exceeding 21 months and prolonged survival over 33 months despite a low TMB and MSS status. To our knowledge, this is the first case of a patient with a gallbladder cancer harboring a POLE arginine 150 stop mutation, which is a non-EDM, and managed with ICIs and achieving excellent outcomes in the current clinical context. The expected survival in the absence of other actionable mutations in unresectable gallbladder cancer is less than 1 year. But in our case, the overall survival exceeded 33 months in this patient due to the extended favorable response on chemoimmunotherapy. Eventually, this patient did relapse after an immune complete metabolic response, but then attained an immune partial metabolic response with reintroduction of GemCis to durvalumab. And we think this might be either due to the presence of this exceptionally rare POLE mutation, which might have influenced the lack of sustained response as compared to other patients, or it is also possible that the underlying tumor biology of gallbladder cancers is different than compared to other GI malignancies, which can become immunosensitive again with chemotherapy rechallenged to regenerate a metabolic response. The next 2 cases were patients with advanced or metastatic CRC with both POLE EDM and non-EDMs. The MSI was not high, and the TMB was elevated in both cases at baseline, and these factors led to the initiation of pembrolizumab. Both patients achieved immune radiological responses exceeding 15 and 33 months respectively. They also sustained immune complete metabolic responses for a duration greater than 2 and 4 years each. And ctDNA negativity was confirmed towards the end of immunotherapy in both cases, which prompted surgery with R0 resection in one patient. And overall survival was 32 months and 58 months in each patient. I should also add that although our study demonstrates a favorable response to ICIs in POLE mutant patients, these findings are hypothesis generating and require further validation in future studies. This could be using a basket clinical trial design by enrolling patients with advanced solid tumors with confirmed POLE mutations given the rare incidence of POLE variants. These trials would also benefit from integrating predefined imaging and serial ctDNA sampling schedules to allow robust longitudinal analysis to correlate molecular dynamics with radiological response and relapse.